Welcome, everyone. I am Evelynn Hammonds, co-director of the Wayne Morse Center for Law and Politics and professor of history at the University of Oregon. We are so happy that each and every one of you can join us today. We hope that all of you and all of your loved ones are healthy and taking very good care of yourselves. The mission of the Wayne Morse Center is to promote civic engagement, inclusive democracy, and justice by bringing together students, scholars, activists, policymakers, and members of communities, people just like you. We discuss a wide range of issues affecting Oregon, our nation, and the world. We work in the tradition of Oregon Senator Wayne Morse, who believed that political independence and education were the building blocks of justice and democracy. Today's talk by Professor Evelynn Hammonds, Historicizing COVID-19, Challenges and Questions, is the final event in our two-year exploration of science, policy, and the public. What an extraordinary time it has been to tackle so many urgent public issues related to this theme. If you have been with us for any of our other programs, I hope you have learned as much as I have. Professor Hammonds' talk is supported by the Lorwin Lecture for Civil Rights and Civil Liberties. We are also grateful to our co-sponsors, the Black Studies Program and Minor, the Global Health Minor, the Department of Women's, Gender, and Sexuality Studies, and the Department of History. We are especially grateful to members of the Wayne Morse Circle. Circle members provide critical support for our programs through annual donations, small, medium, and large. Please consider becoming a Wayne Morse Circle member with a donation of any amount celebrating our 20th anniversary this year. You can find information about that in the chat, and also about how to add yourself to our mailing list so that you can stay in touch with our events in the future. Finally, a big thank you to my wonderful friends and colleagues at the Wayne Morse Center, Thea Croman, Rebecca Dinwoody Flynn, Abby Stilley, Dan Titchener, and Christine Waite. I can't begin to tell you what a pleasure it is for me to introduce Evelynn Hammonds, but I'm going to give you only the tiniest taste of her wide-ranging accomplishments. Professor Hammonds is the Barbara Gutman Rosencrantz Professor of the History of Science and Professor of African and African American Studies at Harvard. She has been on the Harvard faculty for 19 years and currently serves as chair of the Department of the History of Science. She also taught at MIT for 10 years in the program on Science, Technology, and Society. Hammonds has an undergraduate degree in physics from Spelman College and another in electrical engineering from the Georgia Institute of Technology. She earned the SM in physics from MIT before pursuing her PhD in history of science at Harvard and doing a postdoctoral fellowship at the Institute for Advanced Study in Princeton. Her research focuses on the history of scientific, medical, and socio-political concepts of race and gender in the United States, and her publications on race, gender, sexuality, science, and medicine have been published everywhere, it seems, in Nature, Science, The American Psychologist, and in numerous anthologies. She was elected to the National Academy of Medicine in 2018 and the American Academy of Arts and Sciences in 2021. Hammonds has also been honored by organizations ranging from the History of Science Society and Spelman College, her alma mater, to the YMCA and the Lawyers Committee for Civil Rights and Economic Justice. At Harvard, she currently serves on the university-wide committee to examine Harvard's relationship to slavery. She also serves on the faculty executive committee of the Peabody Museum, and she chairs the steering committee on human remains in the Harvard Museum collections. She has been a tireless advocate on behalf of equity and inclusion in STEM occupations and education. She is, for example, a member of the Committee on Women in Science, Technology, and Medicine of the National Academy of Sciences. She was also a member of President Obama's Advisory Committee on Educational Excellence for African Americans. Her work has explored the history of epidemic disease, from diphtheria through AIDS, and I'm certain that that research informs her talk today about historicizing the global pandemic we currently face. Professor Hammonds will speak for approximately 45 minutes, and then there will be plenty of time for Q&A from you, the members of our audience. Please submit your questions via the Q&A button at the bottom of your screen. You can add your questions at any time, although they won't be visible to members of the audience. I promise I will get to as many as I possibly can. Professor Evelynn Hammonds, a very, very warm welcome to the Wayne Moore Center and the University of Oregon.
Thank you, Ellen. That was a wonderful introduction. That was so great. I'm very happy to be here. I want to say this is my first time in Oregon, and it's virtual, so it's very odd, but I am happy to be here to talk with you all this afternoon. So I'm going to share my screen and see if we can get started. Okay, I'm going to hopefully, there you go. Okay, so I have some slides, and I'll sort of add additional information about what's happening as we go along. So first thing I want to say is for historians in public health who study disease, we use epidemics as a kind of sampling device to analyze societies. And one of the leading American historians of disease, Charles Rosenberg, noted that outbreaks of disease in a society can illuminate, quote, fundamental patterns of social value and institutional practice, unquote. But until the outbreak of HIV/AIDS in the 1980s, historians, physicians, and public health practitioners had really become accustomed to thinking that our modern society was no longer going to be subject to widespread infectious diseases like tuberculosis and cholera or smallpox, which really ravaged much of the world in the 19th century and even further back in the past. But what we have now is a pandemic that has roiled a lot of the kind of complacency and sense of being free of infectious diseases has revealed. So the first thing that I always say when I talk about this is pandemics do not produce inequalities, they reveal them. And there were three crises that defined the summer of 2020. There was the worsening pandemic of COVID-19, of course. There was escalating violence, police violence against people of color. And there were demands for dismantling systemic racism in US institutions, including scientific and medical ones. And I want to emphasize that a call to dismantle systemic racism in US science and medicine is unprecedented. And the number of voices that have come out since last summer to address these issues is nothing short of astonishing. As recent as last week, the Journal of the American Medical Association made it very clear that they were changing all of their policies related to racism and how they've addressed racism in that very esteemed journal. And in fact, a paper that came out as well last week noted that of the more than 200,000 articles that have been published in 30 years in journals like JAMA, the New England Journal of Medicine, the British Medical Journal, and the Lancet, less than 1% was the word racism found anywhere in the text of those articles. So this is truly a reckoning in medicine and public health that has long been coming. And all the issues that we've talked about in terms of this particular pandemic have disproportionately affected communities of color. While the killing and maiming of people of color by state authorities is far more visible, the extraneous failures in healthcare and public health are much more numerous. And one of the things that has been revealed is the privatization of healthcare and the failed policy decisions by the US government last year have led to persistent, stark racial disparities in health. The coronavirus itself, the pandemic, has revealed and exacerbated many disparities. Just a quick note for people who don't pay attention to the science of diseases. The coronavirus disease 2019, COVID-19, is currently defined as an infectious disease caused by a newly discovered coronavirus. Most people infected with the COVID-19 virus will experience or have experienced mild to moderate respiratory illness, and many recover without requiring special treatment. But older people and many other people with underlying medical problems like cardiovascular disease, diabetes, chronic respiratory disease, and cancer are more likely and have been more likely to develop serious illness and death. The COVID-19 virus spreads primarily through droplets of saliva or discharge from the nose when an infected person coughs or sneezes. So there are three issues I want to address today. The role of history, the disproportionate impact of COVID-19 on African-American communities, and as I noted just a minute ago, the renewed attention to systemic racism in US science, and I should add medicine and public health as well. The role of history. So it is not hyperbole to state that the history of medicine, especially the history of disease, has never been more relevant than it is today. Historians of medicine have been called on to provide a historical perspective about every aspect of the COVID-19 pandemic, from what do we know about the origins of the pandemic? What lessons can we learn from previous epidemic outbreaks? What's the history of racial health disparities? What's the history of racism in medicine and public health? What's the history of vaccine hesitancy? I would just say, as an aside, that the major question that continues to be raised, certainly by journalists and people in the media, is what lessons can we learn from previous epidemic outbreaks? This time last year, that was probably the single most asked question. And when I say that our work has never been more relevant, I am talking about the fact that myself and many of my colleagues have been asked to be on MSNBC, CNN, so international news organizations, the BBC, Australian news, Al Jazeera, all over the world, people have been calling and asking us to try to answer and give some historical perspective to the pandemic that we are now still in the midst of. And for many of us, it was an odd kind of moment because historians don't necessarily think much about the relationship between disease outbreaks right now and disease outbreaks in the past, because the context, the historical context, is so profoundly different. And yet there are many, many resonances that we've all come to see as this pandemic has unfolded. And as historian Keith Wayloo noted in a forum in the American Historical Review, those who study epidemics and pandemics in the past, we see these powerful echoes in the present crisis. And these are echoes that speak to things like, in the past as today, families and societies grappled with sudden, tragic loss of life. This is something that, again, this pandemic has brought to the fore in ways that people in the 19th century would have recognized with respect to cholera, where, say, a father would walk out of the house in the morning and come back home and sit down at dinner and die at the dinner table. There was nothing unusual about that in cholera outbreaks in the 19th century. We know that in the past, there were debates about the social and economic fallouts from epidemics. People in the past struggled with tensions over the halting of commerce, the imposition of quarantines. But at least quarantines, as one of my historian friends quipped the other day, at least in the past, the quarantines were 40 days. You at least knew how long they were going to last. But today it's quite different. And we also there were many social distancing measures that were used in the past. People would walk on streets and stop walking on sidewalks and walk in streets. People who had means to leave cities would do so and move to the country. All these kinds of things are very familiar. In the past, people tried to make sense of the different impact of disease across regions and populations, among the rich and the poor. And they also sought cures and prevention measures. Even as now and then, there were dubious theories and fraudulent practices sprung up all over the place. And people argued over what forms of knowledge or faith would guide them through the calamity. There were days of healing held, certainly in Boston, in various outbreaks of smallpox, for example. People in the past also called for reinventing public health during the crisis and for rethinking social priorities once the epidemic society. And even as the toll of disease waned or even widened, they planned for what was for them, as it has been for us, a very uncertain future. So these are resonances that really speak to us from the past and past outbreaks of epidemic diseases. But the challenges, as I said, one of the first questions that media people asked about last February, March, and April in 2020 was, what were these lessons? What can we learn from the past, these prior epidemic pandemics? Actually, the question should have been posed differently. It should have been posed as, what have we forgotten about what we learned from past epidemics? Because that is actually the more salient problem. People today think that social distancing is something that it just emerged out of the response to COVID. But as I can assure you, there's social distancing being practiced in the 14th century during the plague. Staying away from, keeping people separate, the sick from the well, the obvious contagious from those who are not contagious, is something that humans have done for many, many time periods. But the first epidemic that people wanted to ask historians about, it seemed this time last year, and not so much now, is what happened in the outbreak of the 1918 influenza epidemic. So the US experience in 1918, in case you don't carry these facts around in your head like I tend to do, from September 1st, 1918 to April 5th, 1919 in the US, there were more than 10 million cases and 500,000 flu deaths. 500,000 flu deaths, comparable to what we've had with COVID. Worldwide, there were hundreds of millions of cases and 50 million flu deaths worldwide. And remember, this is right around World War I. And questions that people asked about were, which communities controlled the disease and which ones did not? How effective was social distancing at this point? How effective were school and business closings? How effective were public gathering cancellations? And historians concluded that early, sustained, and layered application of non-pharmaceutical interventions like quarantine and isolation, school closures, and social distancing actually played a critical role in mitigating the consequence of the 1918 influenza pandemic in the United States. Those non-pharmaceutical interventions sometimes do not appear to work well, historically or in our current computer models. Because if isolation or social distancing policies are not well implemented or implemented too late or for too short a time period, the triggers, when to pull them and when to release them, are unclear and difficult to hit just right. And I think many of you can think of instances where that has happened to us here in the United States in the last year and in other countries as well. It's also true that all social distancing strategies raise a host of practical, ethical, and legal dilemmas that often demand adjudication by leaders, or not. So social distancing strategies, of course, the one that comes immediately to mind for all of us is the wearing of masks. And we all know that across the United States, the wearing of masks has been absolutely uneven. In some communities, people have taken it up quite easily, voluntarily. In some places, it has been mandated. In some places, it has been left to each individual to make their own decision. And some places, it's been absolutely forbidden. And that uneven implementation of social distancing clearly contributes to the spread of COVID, as it did to the spread of influenza in 1918. And in 1918, school closure in particular raised important social questions of, where were children supposed to stay during a pandemic? How were people going to keep them healthy and nourished and fed? And what were going to be the issues for parents and the supervision of their children and leave from work? So these were elements of the 1918 influenza epidemic. And the other thing we should note about it is it was an epidemic of a very virulent flu that is still being studied because it was so virulent. It really attacked young people, in particular young men. And there were a lot of young men at the time of the outbreak in April 1918 who were in the Army, who were housed in close quarters in Army barracks. And the flu spread through those barracks like wildfire. And so we do know that keeping people in close quarters in the outbreaks of infectious diseases is a very, very dangerous thing to do. But one of the things that I was surprised about, few scholars addressed the issue of race in the 1918 epidemic. And it's an interesting point because when the 1918 influenza epidemic began, African-American communities were already beset by many public health, medical, and social problems, including racist theories about Black biological inferiority, racial barriers in medicine and public health, and poor health status. For example, in Chicago during 1918, there were only two hospitals, two very small hospitals that were open and available for the African-American community in Chicago, which was swelling at the time as a result of the Great Migration. Black physicians could not obtain privileges to put Black people into white hospitals in Chicago. And so the amount of access to medical care that the Black community had in Chicago during this epidemic was very small. They tried to address these problems. Community groups in African-American communities mounted efforts building makeshift hospitals. Professional organizations tried to help people figure out how to isolate themselves. And they continued to have to, in public, repudiate racist scientific theories about their so-called immunity. And what happened contradicted prevailing theories about African Americans' increased susceptibility to disease, because it appears that during the 1918 epidemic, the incidence of influenza was lower in African Americans. It's not clear why, and people are still debating that. One possible answer is that residential segregation was so severe that African American communities were kept to themselves, and the influenza didn't seem to penetrate those barriers between communities as easily as it spread among white populations. But although the 1918 epidemic had a less devastating impact on African American communities, it still overwhelmed their really paltry medical and public health resources. These observations about the lower rates of influenza in African Americans did not derail white observers from making speculations about the biological inferiority of Black people, nor did it overturn conceptualizations of Black people as disease threats to white people. So the fact that residential segregation was so severe in Chicago was because, in general, white observers, physicians, and public health leaders thought that that would protect white communities from rampant disease that they claimed to have observed in Black communities. But this case, there was this puzzling paradox that Black African Americans did not seem to be dying as much from influenza. When the epidemic ended, the major problems that African Americans faced still remained. And few historians have noted this point, because for most outbreaks of epidemic disease, certainly in the 20th century, African Americans have borne a heavy burden of disease in their communities, because of the poor health infrastructure that existed in those communities and continues to exist in many respects. So one of the things that happened this time last year, and historians of medicine have been commenting on this since last March and April, and this time last year in May as well, that some historians of medicine were surprised that cases and the incidence of COVID are rapidly spread in communities of color, in particular African Americans and Hispanic communities. I certainly was not surprised. As I said, I started this by looking at the ways in which pandemics reveal inequalities. And we still have massive inequalities across the United States with respect to access to healthcare, health insurance, residential segregation, and all of those things in communities of color, and particularly those that are very low income communities. So I was not surprised that rapidly, and this is talking about data starting to be collected in February, but by May, it was very clear that COVID was spreading very, very rapidly in communities of color. The US Centers for Disease Control estimated that COVID-19 case and hospitalization rates are at least 2.5 and 4.5 times higher, respectively, among Black, Hispanic, and Native American populations than among white populations. Black individuals have died from COVID-19 at more than twice the rate as white individuals. And area-based studies have similarly revealed that COVID infection and death rates in socially disadvantaged areas with large racial and ethnic minority populations have had a very high burden of disease and death. And in the context of intergenerational structural inequalities in the United States, these trends are as devastating as they are unsurprising. Most significantly, we also know very little about the long-term effects, and this is of COVID infection and disease. And there's increasing concern that there are some very serious long-term effects. So as one of my colleagues said, think about Boston. And if someone had asked me this time last year, where were going to be the highest number of cases in the city, which neighborhoods were going to be disproportionately affected, I immediately said Chelsea, which is right near the area of Massachusetts General Hospital, going a little bit north of there. And I said Dorchester, which is a heavily African-American and immigrant community, a little bit south of downtown Boston. And those turned out to be the two areas that have had incredibly high rates of COVID. And my colleague said, well, why did you think that? I said, have you been to Dorchester? Have you been to Chelsea? If you've been to Dorchester, just drive through. See how many CVS drugstores there are there. See how many big box supermarkets that are there. See how many and how densely populated it is. How many 3, 4 triple deckers there are packed in on city streets. And it's a densely populated area. It's an area populated by people who do a lot of the quote unquote essential work. And it's a place where there's difficulties in transportation. And I also, because most people in the United States, their health insurance is tied to their employment. As stores began to close and businesses began to close, it was clear that these were communities where people were going to be losing a lot of jobs. And the density is a key factor. These were clearly places, neighborhoods, where there were a great number of multi-generational families living together in small spaces. If you put all that down on a piece of paper and look at the city, the neighborhoods around the city of Boston, in my view, it was easy to see. And so I was not surprised at all that this is where the outbreak of the disease struck so hard. Many data scientists who track the counts and death tolls are really horrified by the disparities that have been revealed. And many of them worry that we really may not know the true gap because of the available data. In the United States, data on infection rates and deaths are sent from the states, from local areas to their states send them up to the CDC. And the CDC produces the national breakdown. But not every state collects data on race and ethnicity and geographical location, how they're counted, what categories they use are pretty different across the country. And one of the lessons that was forgotten from previous outbreaks was the need for a centralized data collection service for the federal government so that there could be some kind of serious surveillance of outbreaks of disease. Whatever has happened to that project, it's very clear that it broke down in the case of COVID. And there are lots of things that are happening. They're noting, where people are noting in some Hispanic communities that a lot of young people are dying at much higher rates than has been expected. And so people are young working age adults, parents of school age children are dying. We have yet to take in the large distribution of COVID across the country and its specific and local impacts. And that's something that I suggest is going to be the work of historians and other social scientists going forward for quite a while. So the next question that media often asks historians during this time is, give us some explanations about what's happening. Why would there be a disproportionate impact of disease on communities of color? And I've just told you how I think about it. But here are some of the factors that people have noted. High rates of existing chronic diseases like diabetes, hypertension, asthma, and obesity. Greater likelihood of being uninsured, and noted that before, and thus less access to healthcare. More exposure to the virus due to holding more low-wage jobs in food services, public transit, hospitals themselves, and other public-facing jobs. And the fourth one, decades of discrimination and distrust, which leads to avoidance of the white-dominated healthcare system in this country. Number 5 is rumors persisted and really traveled fast around the country that Black people, at first, on much of social media, there were stories that said Black people were less susceptible to COVID. And then following that, more and more media reports began to say that Black people were more susceptible to the virus due to biological differences between the races. That's a very old claim. And of course, 6 is structural inequalities in health, wealth, housing, and education. And all these points, 1 through 6, are elements of every outbreak of epidemic disease in US cities that I have studied from the 18th century to the present. You look at what happened in yellow fever outbreaks in Boston in the 18th century. You can look at smallpox epidemics later on in the 18th and 19th century. You can look at outbreaks of cholera, diphtheria, scarlet fever, tuberculosis. These are elements that you see all the time, especially in urban areas. But the roots of these disparities are deep and difficult to disentangle. Chronic illness might stem clearly from diet or a lack of health insurance, but it doesn't explain really why Black and certainly other Latinx Americans are more likely to suffer from food insecurity or to work in low-paying jobs in the first place. And to answer those kinds of questions, you have to dig deeper. You have to look, you can't just look at the history of how the disease is revealing the inequalities. It has forced us to look more deeply at the history of the inequalities themselves. And the conclusion that many of us have drawn is that the ultimate driver of the production and persistent production of health inequalities in the United States is systemic racism. How do we get here is the issue. And I don't have time today to give you a full reading of all of that, but I just want to make some points. I and other historians have turned to detailed studies of the history of racial disparities in the US from 1619 to the present. There has never been a time in the United States without racial health disparities. Although the terms health disparities is of recent origin, differential health outcomes between Blacks and whites have been part of the American landscape for 400 years. The sophistication of the analytic approaches taken by journalists, social scientists, government agencies, or health scholars may differ, as do the objects of study, but the narratives are very much the same. And one reason that persists, and it bears being taken apart, the reason that continues to persist about the origins of such disparities are supposedly either in the Black bodies are different than white bodies, or inherent in the inequalities that have shaped the Black experience for centuries in the United States. So in order to really get at this, then history actually matters. We have to understand what happened during slavery and at the end of slavery. During slavery, the health care of slaves is deeply dependent upon the owners of the slaves. At the end of slavery, what's really clear is the formerly enslaved became a refugee population in the South, and were subject to the ravages of very, very serious outbreaks of epidemic diseases post 1865. Then we have to continue to analyze the failures of Reconstruction, because it was in Reconstruction that the federal government, for the first time in the 1870s, provided healthcare to the newly freed peoples via the Freedmen's Bureau, a government agency that had a medical agency as part of it that had to respond to the dire situation that the newly freed slaves were facing. They didn't have homes anymore. They didn't have jobs. They didn't have access to food. And there were smallpox and cholera epidemics raging at the time. We have to deconstruct how theories of racial difference provided a naturalistic explanation for restricting African Americans' access to jobs, education, economic opportunities, and adequate housing, and how those things affected health status. This idea about racial difference, that Black bodies are different than white bodies, Black bodies are subject to different diseases than white bodies are, is something that has been a pervasive ideology in medical theory and practice since the 17th century, and has come forward in time. We also have to think about questions of public health practices, certainly those beginning in 1900, which focused on keeping whites separate from Blacks who were viewed as the sources of contagion, right? Because public health experts who are looking at how to control outbreaks of disease in populations argued germs know no color line. So they argued at that point that the health of African Americans had to be considered by white leaders and observers, because Black people worked in people's homes. Black people worked in factories and in occupations and in places where white people congregated. And so to protect themselves, white people needed to provide some kind of healthcare and protection to African American communities. This was not done in any way to protect the health or improve the health of Black peoples, but only to protect them from being vectors of infection to whites. This continues, this process, throughout the 20th century. Jim Crow segregation had a really strong and deep impact on what happened for African American communities. I've talked about with the lack of hospitals, the restrictions on training for African American physicians, both educating physicians after the early 20th century. There were only 3 medical schools for African Americans. There were many African Americans who applied to larger, more prominent white medical schools were denied admission. This goes on for a long time. The infrastructure for supporting hospitals, which, as many of you know, often depends on philanthropy and support from what we call the healthy patients. The patients who did well and were well served in a hospital, those people of means often donate to hospitals. The Black community did not have the wealth, the economic ability to support hospitals, especially in a time when they continue to be increasingly needing more technological tools to provide the best kind of healthcare. So the Black community was, as a whole, Black communities around the United States were at a deep and serious disadvantage. And this goes through the period of the end of Jim Crow, through the Civil Rights Movement, and into the end of the 20th century. And in some places, there's still very serious pockets where access to healthcare is shockingly bare. And so what Black people have done and Black communities have done is really had to figure out ways to take care of themselves. And there are many wonderful stories of Black health activism from the period of the end of Reconstruction all the way through the Civil Rights Movement. And that has resulted in some progress for sure, but there still means that there have been persistent problems that have been impossible for Black communities with all of their activism and dedication to solve. And Ed Beardsley wrote a wonderful book called A History of Neglect, and he looked at healthcare for Blacks and mill workers in the 20th century South. And what he noted, which I think has always been a very powerful comment in my view, is he said the continuing health lag was apparent even in North Carolina, the state that had long been the region leader in public health programs and commitment. But in 1981, the North Carolina Board of Health published an accounting of the 10 leading causes of deaths for Blacks and whites. And this accounting, he said, revealed that with 2 exceptions, that Black men and women perished at rates that were consistently and significantly higher than white rates. And he made the point that I think is key to this sketch of the history I'm trying to provide you. A grim reminder that to a too large a proportion of Black families in North Carolina and every other Southern state live outside of every legal, medical, and social advance that our nation has made in this century. It is that continuing legacy of slavery, of Jim Crow segregation, that is in fact continuing to reproduce the health disparities that exist. So let me show you this slide from the Proceedings of the National Academy of Sciences. If you look at graph A, this is age-adjusted mortality, 1900 to 2020. The dark line is for whites, the blue line, the lighter blue line is for Blacks. As you can see, there's never been a time between 1900 and 2020 when mortality rates of Blacks was lower or even equal to that of whites. If you look at slide 2, slide B, you see life expectancy. And what you see from 1900 to 2020, the life expectancy of whites, the dark line, is higher than that of Blacks, the light blue line, except for one point. And that one point is 1918, the influenza epidemic that I described earlier, which is notable for what had happened there. And many of us are still trying to analyze a lot of the data that's now been made available to try to figure out what really happened. It was notable in Black newspapers across the country, in Baltimore, Chicago, Atlanta, that this was the influenza didn't affect Black people the same way. Nobody really understood, and we still don't quite understand it today. But that's the only time between 1900 and 2020 where the life expectancy of Blacks was closer to that of whites. As you see, the highest ever Black life expectancy in 2014 is below the white levels since 1989. These are the data that tell us what COVID has revealed to us. So once again, COVID made clear the connection between poverty and public health. Black and Latinx people are more likely to contract and die from the virus. And again, the reasons we keep saying is that they disproportionately work in low-paying jobs. Some cannot practice social distancing. And these factors are about economic inequality and have existed for more than a century with little improvement as the structures of racism have barely been changed. In the end, it's clear that the need to address systemic racism should be part of the mandate of medicine and public health, including a historical perspective that can tell us where we have been and how we as a nation have failed to incorporate lessons from previous epidemics that revealed the role of systemic racism in perpetuating health inequalities. And I love this quote from Jack Geiger, who's a physician, medical activist who died just a few months ago. He wrote over 20 years ago that history is important. Why? Because it underscores the extent to which racism, fluctuating in intensity, shifting in content, but ever present, is still a major public health problem and a challenge to the goals of medicine and of science. And he continued, the failure of efforts to address racism reflects an abandonment of racial justice and equity as national goals. It's not just history. It allows us, the history allows us to trace what we have not done, what lessons we have not learned. And it also, I hope, helps us to look and see what we might do to produce a different future if we indeed make clear what the lessons of history are. So I think I'll stop there.
Thank you so much, Evelynn, for that very wide-ranging and interesting talk. Now is the time for you, the members of our audience, to file your questions in the Q&A button at the bottom of your screen. And let me just start by asking a question of my own from perhaps where you began. Why do you think, as a fellow historian, why is it that we persist in forgetting so much of what we knew? I presume your comment was a kind of broad cultural observation about how we forget what we used to know about past pandemics. And is there, how do you have any ideas about how we might remedy that going forward?
Yeah, it's a really good question, Ellen, and it's both about, historians writing about, shifts and changes in American culture and society, but also just, as you said, it's the broad, it was what I was trying to make the point for both professional historians, but also just in general in the culture. And I think one of the things that happens is that once you're out of these kinds of crises and things go back to quote unquote normal, then the reasons that normal is possible get lost because people no longer see, right? What things are built into our system, why they were built into the system and why, and so we can't react to them. So for example, let's talk about childhood immunization, right? And with the outbreak of diphtheria throughout the 19th century, children under the age of 5 were the primary victims of diphtheria. There were villages, say in upstate New York, a small village that had a school. An outbreak of diphtheria could kill every kid in that community. It was shocking. People had the expectation that most children weren't going to live past the age of 5. There's so much disease around. And slowly but surely, as better therapeutics came along, and certainly with the introduction of toxin antitoxin and immunizing all school children, That's why we don't see diphtheria. It's not that diphtheria is gone, but because everybody gets immunized from it, you don't see it. Right now, if somebody had a case of diphtheria and you took your kid downtown to the great Massachusetts General Hospital, most of the people in the room wouldn't even know what it was, right? But you can test for it and you would find out. But the fact that we do immunize our children, not necessarily for every infectious disease at the rates public health people would like, but people had clearly forgotten. That's why we do it. There was so much death, and it's under control. And so, but when I'm listening now, there's certainly always been anti-vaccine people as well, for sure. There's been a lot of protests about that across the 20th century. But most people are pretty okay with the early childhood immunizations, right? And so when I listen now and I hear these, really sort of wild, hyperbolic comments, and there's no other voice that says, but don't you realize this is the way to get to disease control? And we already do it because we get our kids immunized, 4 or 5 different shots now before they go to school. It has made all the difference in the world. And Perry Klass, who writes for the New York Times, is going to be writing some more commentary about that in the next few weeks. And so you can see how sort of everyday people on the ground might forget. But one of the things I'm struck by, and some of my colleagues we're trying to figure out, is why when historians write about cultural and societal shifts, don't necessarily turn to the role of public health and preventative practices and the ways in which they make the modern world possible, right? Stuff like sanitation, clean water supply makes it possible for people to live in cities. And before there were such clean water supplies and those kinds of public health interventions about crowding and those kinds of things, there was a lot more disease. So it's just simply that a world where disease was so present is a world we think we are far away from. But even though we're not. And so I think that's part of the forgetting. I hope, lots of us hope, that this is the most important wake-up call we could possibly have, to remember that these kinds of things are absolutely what should be front and center when we talk about political issues as well as health issues.
Yes, absolutely. And we're still working on access to clean water as a human right. We have a few questions from people in the audience. What differences or similarities do medical historians of medicine and public health notice with the COVID-19 pandemic compared to previous disease outbreaks that were attributed to particular locations or groups of people? So, for example, the 1918 flu pandemic, often called the Spanish flu, and MERS is another example when examining the current prejudice and discrimination against minority groups, including Asian populations.
Right. So, what historians of medicine and public health think is that it was so predictable. It was so predictable that there needed to be some way for certain kinds of leaders, certain of our leaders, to distance our country from other countries. The disease couldn't have been here except for some bad people there, right, over there. And it's not something and so that kind of stigmatizing is a feature of almost every kind of outbreak of disease that affects a large numbers of people. But one would have thought that here in the United States in the 21st century, that people would have recoiled from that kind of stigmatization. But when it's stated by government leaders, both at the federal level and at the state level, and at mayors and at the very local levels, then people it just sets up that whole thing of ways of othering groups that can be othered because of their social status, because of pre-existing prejudice and bias toward those groups. And it's just an easy way to do it. But the other interesting thing to me is the ways in which some people began to believe it. So I grew up in Georgia. So I was watching some of what was happening in communities outside of Atlanta, and in the sort of larger and predominantly white suburbs outside of Atlanta. And I noticed in a news report that the people in these white suburbs were not wearing masks. The stores, local shops were not closed because they felt as long as they lived in gated communities where they could keep people from brown and Black people from Atlanta out of those communities, they were fine. And it just was so striking to me that is the kind of reaction that people would have, and that it would be supported by other voices. The other thing that's very clear about this processes of stigmatization and bias is the ways in which the voice of public health experts and medical experts began to be devalued. I mean, Tony Fauci at this point, there are places where he's absolutely vilified, right? And so we've now witnessed a moment where expertise, a particular kind of scientific and medical expertise, is considered in wide swaths of this country not believable. And people would rather return to that sense that as long as I stay away from people who are not like me, who don't live the way I live, who don't share my phenotype as well, then I'm fine. But the thing is, COVID doesn't care. It doesn't care. And so these kinds of processes of stigmatization are absolutely guaranteed to be undermined, and they have been. And it's why we can, and it's one of the major reasons we cannot get control of this thing, because of those kinds of beliefs. And they do emerge, and it's a reaction to uncertainty, fear of death, those kinds of things that emerge for a whole host of factors. But disease just makes them more intense and more acute.
Thank you. Here's another question. Do you think that what we learn from the current pandemic will improve the deeply embedded racial or disparities, or perhaps the questioner means diminish the racial disparities in healthcare in the future? Or do you think these inequalities will go unchanged when we go back to normal and forget what we knew? And let me just add that in addition to the very lengthy and stubborn history of racial disparities that you recounted in this country's history, there is also a long history of health and civil rights activism that has tried to do something about that. Yep. Is there anything about the current moment and the current effort to interrupt those disparities that stands a chance of changing the kind of the long-term pattern that you have outlined?
I'm gonna I keep on the days that skepticism overwhelms me, then I try to think hard about what some people on the ground are trying to do. One story I can tell you, which I think is illustrative, is I teach a course at Harvard. I just finished it last week, called "Sick and Tired of Being Sick and Tired: Health Disparities in Historical Perspective." And so it's many episodes of Black communities around this country who they have to do something to try to help people who are dying around them. Everything from petitioning the government in the 1870s when Rebecca Crumpler, who was one of the first African-American women to get an MD in this country, wrote after she was working in Richmond with a free population. She wrote to the government and said, "We are free now and we're citizens. And now the government, and what a right of citizenship should be good health care." She raised that point in the 1870s. And so Black communities continue to try to help with limited resources And you're right, I tell us this, and my students were pushing me back. They say, Professor Hammonds, this story is more depressing every week. People are trying, but what does it take to get deeply to the structures that produce these inequalities? Other things that have happened just before I end that point is that one of my students also pulled together, he's a pre-med student at Harvard, pulled together a bunch of his friends, and they created a little NGO called We Got Us. And they just took themselves out into Black and brown communities in Boston, delivering flyers, helping people get access to vaccinations, just hitting the streets, door to door. And that's something that Black people have done before. In fact, when W.E.B. Du Bois first started charting these health disparities in the most rigorous statistical way, what did he do? He went door to door in Philadelphia. The Philadelphia Negro is one of those first and very serious and detailed studies. And then he wrote The Health and Physique of the Negro American, where he continued that kind of work, showing that health disparities were rooted in the socioeconomic inequalities as well. And so, and the last one I would say is apropos the history of the Philadelphia Negro, a bunch of Black doctors in Philadelphia who found that so many Black people were having a hard time getting tested for COVID and subsequently getting vaccines. What did they do? They bought a van. They started going into Black neighborhoods in Philadelphia and they started testing people. They just started testing people because it was harder and harder for Black people in Philadelphia to get tested. And there speaks to questions of they were trusted members of the community and they were able to make it in. These kinds of efforts have existed over and over again, including right before World War II. Members of the Alpha Kappa Alpha sorority bought a car, filled it up with all kinds of medicines, and went traveling through the South and stopped in places that had never even seen a thermometer and to help folks who had never seen doctors or had any kind of care. They're wonderful, absolutely essential kinds of activist healthcare projects, but they don't speak to structure. Because, at this point, if we don't have structural change in the medical and public health system, those kind of efforts will continue and they will be stopgap measures, but they won't get to the heart of the matter. And the very next thing that happens, we'll see disproportionate impact on brown and Black people who cannot access the best kind of care in this country. So,
sure. Yeah, Evelynn, one more, just to pursue this just a tiny bit more. Sure. I think in terms of the current pandemic, efforts to mobilize and enlist the voices of trusted community leaders and healthcare workers in communities of color has certainly been part of that long grassroots effort. But it's also been a kind of central part of the federal government's response to the pandemic. And I wonder if in that aspect, you see any significant difference that might actually make a positive difference going forward in terms of these more structural issues that you're pointing out.
So I think what's important is that recognition that you mentioned, which is important, of the federal government, of the grassroots efforts made by public health, medical practitioners, and just plain old regular church folks. The recognition that they play a significant role in getting communities of color, in particular African-American communities, access to care and get them to come into the system, right, has been really important. The reason that recognition, I think, happened is because of the long efforts of African-American social scientists, historians, and folks who keep pushing at this and documenting with ever greater sophistication what these inequalities, how these inequalities emerge. David Williams, who's a sociologist, is a leading person who's worked on sociology of health disparities. And he points to the 2003 report called Unequal Treatment. And it was a consensus report produced by the National Academy of Medicine, which it was the Institute of Medicine at the time, the National Academy of Medicine now, in 2003. And it's 2 volumes of page after page of data and showing in every sector how the disparities, how long they've existed, what constitutes those disparities, and recommendations for change. Slowly but surely, that report had an impact and helped produce the Office of Minority Health in the NIH, right? Numbers of people have been able to be educated about the issues of health disparities. At this point, I think the difference is there are enough people, certainly at the federal level, who understand the problem of health disparities, who are trying to make this moment be a different one, where and speaking very hard to leaders of the government about what's happening. By last summer, when it was clear that there were going to be a number of vaccines ready to roll in the fall, late fall, the CDC held lots of meetings with local organizations because they knew there was going to be a lot of skepticism on the part of Black people about those vaccines. Many of the African Americans members, say, of the National Academy of Medicine were writing op-eds. There are Black deans of medical schools now. They were out there talking as well. Folks who are deans of public health schools. So there's a larger professional voice that's evidence-based, that speaks to these issues, that I think that's making a significant difference, making it harder for the federal government to act as if it doesn't know. So I'm hopeful that that will make the next normal better.
I'm hopeful too. And as we were chatting about before, we heard from one of those new federal leaders, very attentive to disparities just last week, Alondra Nelson.
Yes.
I know you know her. So here's another question, Evelynn, from someone named Neil Hollander. Are there any lessons for solutions to these kinds of health, I'm not sure what this word is, but these health disparities in the Jewish experience in the United States? Any comparisons there that are useful?
Well, I think I think what I know most about has to do with efforts in New York City. Certainly at the moment when much of the Jewish population, or I should say a significant portion of the Jewish population in New York City, concentrated in densely populated tenement areas. As people began to gain better access to, as many of those populations gained better access to education, and also increasingly there were people who were making more money in businesses. And then you see the emergence of many Jewish hospitals, and hospitals that were really oriented toward addressing the burden of disease on Jewish populations in New York City, and then opened up to many other populations as well. So the difference here is that I would say at the moment when that sort of those kinds of efforts happened, the Jewish community was really, in a sense, becoming economically more stable and had many more sources of wealth that could be turned toward philanthropy to support medical care. And the fundamental difference is that happened, that there's more economic resources to be put toward the community by people in the community. The difference for Black and Brown communities in the US is that I would say only recently, in a decade or so, the sufficient, or not even sufficient, but increasing members of African American communities that have wealth that can be turned toward these kinds of problems of addressing healthcare. So the issue is not so much identity, if that was part of your question, or anything, but it's really about who has wealth and who doesn't have wealth, and how that wealth can be used to shape access to healthcare. And the larger question is, will this moment really help Americans understand the dire need for universal health care? Healthcare that's not dependent on it's not employer-based healthcare. It's not so tiered in ways that the wealthy people get the very best and people with lesser means get really bad. Is this moment going to change when we really can have this conversation and say that we have simply, this cannot go on? You see that you can, if COVID locked us all down and forced us to look at a lot of things because we didn't have anything else to do. And I think if it hasn't shown, and that's, I think, part of why these inequalities have become more visible. I was never home at 3 o'clock in the afternoon to watch the news and see people waiting to get vaccines in long lines down the street. I would have never noticed that if I had been working, if I'd been not working, had been working other than at home. And so you see more, we've seen more, and maybe that helps, but it has to be tied to a commitment to make sure there's such a thing as health equity in this country. Those are the kinds of connections that I think is possible. I really do, because of just what I've said. We have a strong evidence base here. And also, what I mentioned earlier, the calls for seriously addressing the systemic racism in public health and medical theory and practice. I think that's real now. I really do. That to me is a way that I think will ultimately help us to not repeat and not forget, not repeat our forgetting, I should say, to do something different.
Okay, here is a different kind of question. You addressed in your talk the disparity in life expectancy numbers over a long period of time.
Yeah.
What effect in the recent life expectancy numbers, what is attributable to gun violence among groups? And I might add to this question, what do you think our chances are of really starting a conversation about gun violence in kind of in the language of public health?
Yeah. So, I don't have that data at the top of my head about gun violence. I know it's a very serious problem, and I don't even think having more fine-grained statistical analysis is what we need when we can sit and ignore these continuing outbursts of gun violence by people who are quite mentally unhinged. And so there's clearly a connection between access to guns and the lack of mental health care in this country that's resulting in the kind of gun violence outbreaks that we see. And so I think that it is personally, not sort of professionally, but personally, I find it difficult to understand how we can continue to act as if these seriously violent incidents do not have a broader root in our society. It seems to me we constantly, once they happen, then there's a lot of media attention to the individual that, and typically it's an individual, perpetrated the violence against multiple members of a workplace, a store, a school. And then there's another story that follows that suggests that there were some mental health problems. And I don't understand why the thread hasn't been pulled to say, what kind of mental health services are really available to anybody in various communities around this country? Because there are clearly people who have needed help. Is there help? What kind of help is there? What do we know about it? What's the access? As an educator, I know in a university setting, we're providing millions and millions of dollars of mental health services to students right now that may not be sustainable for institutions of higher education to do by themselves. There needs to be something else, and it has to come with the kind of money we're talking about and the kind of problem that it is. It's going to have to come from the federal government, which means it's going to be in the political realm. Do we have the political will to put forward now the need for greater mental health services with attention to what is possible to intervene such that the fact that we can't seem to solve the problem of access to guns in any reasonable way, but at least we ought to be able to think about access to mental health to keep people who are mentally disturbed from getting guns. So I think it's a multi-pronged problem, and it's those kinds of problems that certainly long-standing in the US, solved in many different ways internationally. It speaks back to the larger question: is COVID going to be a time? Is this pandemic, as we hopefully are coming close to its being more under control? What kinds of things are we going to put on the table that the country is going to have to wrestle with in terms of distribution of resources to solve? I think that's the ultimate problem.
Mm-hmm. Okay, and I am going to combine a couple of questions in order to ask you one final question. Let's see if I can do this. They come from—
You can do it, you can do it.
They come from Estrellita Castillo, I hope I'm pronouncing her name correctly, and Jose Martinez, who both comment in different ways that scholars like you continue to show that not much has changed in hundreds of years. And this is my comment: that might be another contributing factor to why we keep forgetting what we used to know, is this sort of depressing punchline of a lot of our work. So what steps, including positive steps, can people of all kinds, but particularly members of communities of color, what steps can be taken both within and outside of medical and public health communities to make sure that we actually do make some kind of positive progress in the future? This is a question I think about individual action in the face of challenges that we do appreciate are institutional and structural. But what can you leave us with something positive, Professor Hammonds?
No, I mean, what I'm hopeful about, and what I feel is hopeful in my work to answer that question, what makes me happy, hopeful, is just the work of my student, who simply said, I have got to do something. And he got up and got his friends together, and they went down to the Boston Public Health Commission and learned a lot, and just started going into the community and trying to help people. And he's going to go to medical school. He's going to be a different kind of physician. He's going to bring this work he's done in the community right through his entire career. And I do think it's about ordinary people doing ordinary things. Like, look, if it's hard for somebody to get, there's a commercial on right now with Spike Lee, he's saying Uber, buy an Uber ride for somebody who can't get to the place they need to get to do a vaccine. Everybody can do something right now. And that's just taking an open-eyed look at, people are dying, people are not being able to take advantage of the help that's there. What can we do? And do it. And I think that there are lots of things for people to do. But my hope is that when people start doing the ordinary things, helping people get a ride, helping people get to the drugstore, helping people get to food banks, having Boy Scout and Girl Scout groups help staff the food banks, all these kinds of things that represent in American culture a certain kind of community activism, a sense of care and a sense of community. Because I think what this is we've lost a little bit of the sense of the common good and our common responsibility to each other. And the little things add up. It makes a difference if people feel that they have done, that they went to the food bank and helped out. It makes a difference. And so I hope that this engenders that kind of activism again, in the face of the fact that the larger system that we created and has its problems, it maybe is going to be responding differently to this. And so I think that's one part. The other thing is, I think the focus on the fact that there's been so much pressure coming in up until, as I just said, last week, on really looking hard at the way racism has played itself out in the medical and public health arena. There are communities now who are saying, their local public health offices are saying, racism is a public health problem. That's an amazing thing to have said. I think that's good. It makes it turns this not into, takes us away from personal animus and gets us to focus on systems, I think. And I'm hopeful that it will continue to do so. So I think it's a moment where in these kinds of crises, there's always the kind of basic activism of just being a good neighbor and walking out in the street and helping, to me, is a very good thing. And I think it's crucially important for students. They should not leave my class with the sense of, oh my God, it was one depressing story after another, a failure of the United States healthcare system. But it was also a story of heroic activism by just regular people and just students in a lot of cases who just said, I am going to help my community. I'm going to figure out how to do it and do it. So I that's the part of the story that I always try to emphasize. Yes, I've told you a lot of depressing things, but I've always told you this system is not total and closed. Once people start fighting back and asking hard questions and pushing and showing that when the federal government says we can't do something and regular people go out and say, we just did it. We bought a van and we just took vaccines to people. So it can be done. We're not going to take that anymore. We're going to do it and we're going to show you that we can do it. So I think there's always that dual thing. And hopefully at the end of this, or when we bring it closer under control, some of this is going to stick in ways that it didn't stick before.
Well, I certainly hope you are right about that. And if a pandemic can't do anything else, it should be able to remind us how incredibly interrelated and interdependent each one of us and all of us actually are. Our time with you, Evelynn Hammonds, has just flown by. I want to thank you again so very much for joining us this afternoon. I want to thank all of the members of our audience. It's been a very interesting 2-year journey exploring science, policy, and the public. I look forward to seeing all of you again in the fall when we will be starting a new theme. But in the meantime, please take very, very good care of yourselves, your loved ones, and your communities. Thank you so much, Evelynn.
Thank you. Thank you so much, Ellen. This was great.
Yeah. And bye, everyone.
Bye.